Hello and welcome to Workers Comp Unwrapped, the podcast that simplifies workers' compensation for physicians. I'm your host, Max, here to give you clear, actionable insights to navigate the medical legal side of workers' comp. So, let's get started. Welcome to Season 2, Episode 27 of Workers Comp Unwrapped, the podcast where we explain why, even after your patient leaves the hospital, your billing problems are just getting started. I'm Max, and with me today is Aisha, who brings, 15 years of hard-won experience from the trenches of the workers' comp industry?
That's right, Max. Seen a fair bit.
I bet. Today we're tackling overcoming common denials in post-acute care claims. We're diving deep into those, let's say, frequent objections providers face when billing for things like physical therapy, home health, the works.
Oh, yeah, the stuff that's absolutely vital for getting someone actually better.
But getting paid for it feels like pulling teeth sometimes, doesn't it?
Oh, tell me about it. It's exactly that point. You've done the hard medical work, the patient's improving, and then bang, nope, wasn't authorized.
Or the classic, not medically necessary.
Right, and suddenly you, the provider, are just holding the bag for weeks, maybe months of care you already gave in good faith.
The shared trauma is real, I swear. Okay, so let's unpack this for everyone listening. When we say post-acute care in California workers' comp, what exactly are we talking about?
So basically, it's the medical help someone needs after the initial big stuff, after surgery or major hospital stay. It's all geared towards helping that injured worker get back function, get back their independence.
Makes sense. And what kinds of services fall under that umbrella?
Well, you've got your physical therapy, your occupational therapy, PT and OT, stays in skilled nursing facilities, SNFs. Then there's home health services, maybe nursing or therapy at home, bigger rehabilitation programs too, and of course, durable medical equipment, DME walkers, beds, that kind of thing for use at home.
Right, all the things that actually bridge the gap between hospital and, normal life. And legally speaking, workers are entitled to this stuff.
Yes, absolutely. That's the baseline you got to remember. California Labor Code Section 4600 says injured workers get all medical care reasonably required to cure or relieve the injury's effects. And that includes these post-acute services. It's right there in the law.
Okay, that sounds straightforward enough. So where's the catch? Because there's always a catch.
Slight laugh. There is. Here it is. Those services, everything we just listed, must be authorized. And they have to line up with the state's Medical Treatment Utilization Schedule, the MTUS guidelines.
MTUS, our old friend.
Yep. Think of it as the official rulebook for what treatment is considered necessary and appropriate for which injury.
So the law says yes, but then you have to jump through 100 administrative hoops to prove it's needed and get that stamp of approval first.
That's pretty much the reality of it. Yeah. And that's exactly where the denials start pouring in.
Okay, here's where it gets, as you say, really interesting and maybe a little infuriating for our listeners. Let's talk about the top reasons, or maybe we should call them the top excuses adjusters give for denying these claims. What are you seeing most often?
Oh, number one, hands down, no contest. Lack of prior authorization.
Didn't get the okay beforehand.
Exactly. You provide those PT visits. You send the home health nurse out. You give the patient that fancy knee scooter. If you didn't get utilization review, UR, approval first, it's almost guaranteed to be denied.
Even if it's obviously needed.
Even then, you have to think adjusters are dealing with mountains of paperwork, right? If that specific UR approval isn't attached or easy to find in their system, bam. Denial. It's often just a procedural thing for them.
Okay, that's a big one. What else is on the hit list?
Next up is the old standard, not medically necessary.
Yes. The universal denial reason.
Right. And this usually ties back to those MTUS guidelines again. The insurer basically says, nope, this service doesn't fit the rule book for this injury right now. Or, and you'll hear this one a lot, the patient has plateaued.
The plateau, where recovery magically stops the minute the insurance company decides it should?
Precisely. Even if the patient is still, struggling to tie their shoes or lift their arm, that's a huge sticking point, and it's why your documentation showing ongoing progress or potential for more is absolutely critical.
Got it. Keep proving the need. What else?
Another big one, exceeded visit limits, especially for outpatient PT and OT. There's this sort of soft cap, a presumptive limit of 24 visits per injury. That's in the labor code. If you hit visit 25 and haven't specifically requested and justified and gotten authorization for more visits, those extra ones are going to get denied.
So 24 isn't a hard wall, but you have to ask for permission to climb over it before you get there.
Exactly. Proactive requests are key. Then you get the technical stuff.
Like typos.
Kinda. Incorrect coding or documentation. This one's really frustrating because it's often just a simple mistake. Missing CPT codes. Maybe the ICD-10 diagnosis code on the bill doesn't match the RFA or the doctor's note. Or, and this is crucial, forgetting to attach the detailed therapy notes that actually show what you did and how the patient responded. Any little mismatch can trigger a denial.
It really feels like they're just looking for any tiny reason sometimes, doesn't it?
It can definitely feel that way when you're dealing with the denials, yeah. Timeliness issues are another one.
Too late submitting the bill.
Yep. You've got a 180-day window from the date of service to get that bill in. Missed that deadline. Denied. Also, being late with your RFA for more care. If the old authorization runs out before you ask for a new one, you're in trouble. Timing matters a lot.
Okay. Anything else?
Last one I'd highlight is DME denials. Durable medical equipment. Insurers often push back here saying the equipment isn't really essential or it's more of a convenience item or, surprise, surprise, it wasn't pre-approved.
So the big picture here is, even if the patient desperately needs the care, if your paperwork isn't perfect and on time, expects a denial. It's almost the default setting.
It really is. Making that paperwork bulletproof, as they say, is honestly just as vital as providing top-notch medical care. One doesn't work without the other in this system.
Okay, nobody enjoys denials. So preventing them has to be the goal. What actually works?
Yeah.
What proactive steps can providers take now to cut down the odds of getting hit with these denials?
Right, let's talk prevention. This is how you stay ahead. First off, absolutely critical. Submit detailed RFAs, and I mean detailed, for all post-acute services you think the patient will need. That RFA isn't just checking a box, it's your argument. You need to include specific, measurable functional goals.
Like increase range of motion by 15 degrees, not
Yeah.
just improve shoulder movement.
Exactly. Attach progress reports showing improvement or maybe lack of expected improvement and why you need to continue or change tactics. And always, always link it back to the MTUS guidelines. Be specific.
Objective data is king then.
Absolutely. Subjective feeling better doesn't cut it. Second, you have to constantly track visit limits and authorization periods. Know exactly how many visits got approved, for how long, for what service. Don't just assume the next block of PT is automatically covered because the first one was.
So calendar reminders are your friend.
Big time. Set reminders to get those RFAs for continuation in well before the current one expires, especially for that 24-visit PTOT thing.
Okay, what's next?
Third, attach complete documentation with every single bill. Make it easy for the adjuster. Don't make them hunt. Include your detailed therapy notes for every single date you're billing for. Include copies of the doctor's orders, and most importantly, include a copy of the prior authorization that specifically approves those dates of service. One neat package.
Makes their job easier, less reason to deny.
Precisely. Fourth, it sounds so basic, but use correct codes. Double check, triple check. Do the CPT procedure codes match what you did? Does the ICD-10 diagnosis code match the accepted injury on the claim? Any mismatch is like a red flag waving, deny me.
Got it. Accuracy matters. Last one.
And finally, be sharp and monitor your deadlines. This is important. If you send in an RFA, Utilization Review has a strict deadline to respond, usually 5 business days for regular requests, faster for urgent ones. If they miss that deadline, by law, that service is often deemed authorized. They didn't say no in time, so it's effectively a yes.
Whoa, really? So their silence can be an approval.
It can, but you need to track those response times and push for that deemed authorization confirmation if they're late. Don't just sit back and assume it's denied if you hear nothing.
That's a fantastic tip. So really it comes down to being just as meticulous with the admin as you are with the actual patient care?
100%. The medical care helps the patient heal, but the paperwork, that's what gets you paid for it.
All right, let's be real. Despite best efforts, denials are going to happen. It's just part of the workers' comp world. So that dreaded explanation of review, the EOR, denying your claim arrives. What's the game plan? Step by step, what do you do now?
Okay, deep breath first. Don't panic, but you do need to act fast. First step, review the EOR carefully. Figure out exactly why they denied it. Was it no authorization? Was it medical necessity? Was it a technical thing like a code or a date? The reason tells you what to do next.
Okay, identify the enemy. Got it.
Right. Now, if the denial is purely about billing or coding, maybe you forgot to attach that therapy note or they say the code's wrong, something like that, your first move is to file a second bill review. or SBR. This is your official request for them to take another look at the bill specifically because of a billing dispute.
And there's a deadline for that.
Oh yes, a critical one. You have 90 days from the date you receive the EOR to file that SBR. Miss that 90-day window, you pretty much lose your right to appeal that denial through this process.
90 days. Okay, seems fair, but I imagine that can fly by fast in a busy practice.
It really does. Now, if the SBR comes back and they still deny it or uphold their original denial, you have to move even faster. Your next step is to proceed to independent bill review, or IBR. And for this, the window is much shorter. You only get 30 days from receiving that unfavorable SBR decision to file for IBR. This is where a neutral third-party reviewer looks at the billing dispute.
Wow, 30 days is tight. No room for delay there.
None at all. You have to be ready. Now, here's a really important distinction. If the original denial, the reason on the EOR, was specifically about medical necessity, meaning you are denied the RFA before you even provided the service, and that's why the bill got kicked back.
Ah, so it wasn't a billing error. It was you are saying no up front.
Exactly. If that's the case, you don't go through SBR and IBR for that issue. Disputes about medical necessity that come from a UR denial, those go through a totally separate process called Independent Medical Review, or IMR. Different forms, different deadlines, different reviewers.
Okay, that's crucial. SBR for billing disputes. IMR for medical necessity fights stemming from UR.
Yeah.
Got it.
Very important distinction. And then, kind of downstream, if you've gone through these appeals, maybe IMR, maybe IBR, and there's still a dispute about payment, especially if the whole workers' comp case is moving towards settlement, then you need to think about engaging lien strategies.
Filing a lien.
Yeah, filing a lien with the Workers' Compensation Appeals Board, the WCAB. It basically puts a legal claim on any settlement money the injured worker eventually gets. It secures your right to get paid out of that settlement for the services you provided that are still in dispute. It keeps your claim alive.
Makes sense, like putting a flag in the ground saying, hey, we're still owed money here.
Exactly that. It preserves your potential to recover those funds.
Okay, let's switch gears slightly and tackle some specific questions providers often wrestle with when it comes to post-acute care denials. Let's call it your top questions answered. First one, do I really need a new RFA for every single stage of rehab? Like if someone goes from basic PT to work hardening? Or does the first approval cover the whole journey?
Oh, you definitely need new RFAs as treatment progresses or changes, especially if you're going beyond the time or visits approved initially or asking for visits past those caps, like the 24 for PTOT. Each request for more visits or a different type of service like work hardening needs its own clear justification based on where the patient is now and what the next goals are. Never assume approval just carries over.
Okay, constant vigilance. What about when the adjuster says the patient has recovered enough or hit MMI maximum medical improvement, but you, the provider, see they still have real problems?
Yeah, that's a common fight. You push back hard with data. Recovered enough, or MMI needs proof. Your reports need to show specific, objective, ongoing functional deficits. Measure that range of motion, test that strength, document the balance issues. You have to clearly show the patient isn't permanent and stationary yet and still needs care to cure or relieve the effects of the injury. Prove the treatment is still making a difference or has the potential to.
Makes sense. Fight opinions with facts. Okay, here's a tough one. What if maybe things got chaotic and I just forgot to send the RFA before I started the therapy? I mean, the care was good, the patient got better. Can I bill retroactively?
Look, you can always submit a bill. Nobody can stop you from sending it in, but let's be realistic. If the service required prior authorization under MTUS and you just flat out forgot to get the RFA first, yeah, you should absolutely expect that bill to be denied. Getting retroactive authorization is incredibly rare in workers' comp. It usually only happens in really specific documented emergency situations. Simply forgetting, that's almost never gonna fly.
Ouch. So getting the RFA first is basically not negotiable.
Anything requiring prior auth, yes, absolutely.
Are home health services generally a tougher sell? Harder to get approved than, say, sending someone to an outpatient PT clinic?
Yes, typically they are. They definitely get more scrutiny from adjusters. You need a very detailed justification. Why can't this patient go to an outpatient facility? What specific medical needs require skilled care in the home? How is home care uniquely necessary for this patient's recovery? You have to build a really solid case.
Okay, makes sense. Last question in this section. For providers who are just feeling buried by all this complexity, how does getting help from, say, a specialized workers' comp billing service or a lien expert actually make a difference in overturning these denials?
Oh, they can be lifesavers, honestly, because this is all they do day in, day out. They know the rules, the deadlines, the loopholes. They help make sure your RFAs and documents are rock solid from the beginning, which cuts down on denials in the first place.
Prevention again.
Right. But when denials do happen, they know exactly which appeal path to take, SBR, IBR, or IMR. They know what evidence is needed for each. And crucially, they track and meet all those crazy tight deadlines that are so easy for a busy clinic to miss. They handle the lien filing and negotiations if it comes to that. Basically, they take that whole administrative nightmare off your plate, ensuring compliance so you can actually focus on treating patients. They're the pros at building and defending that bulletproof paperwork.
So boiling it all down, what does this really mean for you, the provider listening right now? I think the main takeaway is pretty stark, isn't it? Post-acute care, your rehab, your home health, it's absolutely critical for patients. But just providing great care isn't enough in this system. If you don't have a solid strategy for authorizations, meticulous documentation, and the persistence to fight denials correctly and on time, you could end up providing incredibly valuable care for free. Just a pile of denial letters to show for it.
That's the hard truth of it. So my strongest piece of advice, never ever assume approval. Even if the patient's need is staring you in the face. Document everything, like you're preparing for court, because sometimes you are. Proactively track every visit limit, every authorization end date, and when you get that denial, analyze it fast. Know the right appeal path, SBR, IBR, IMR, and fight smart. File on time every single time. Don't let those deadlines slip.
Sound advice. Well, that's all the time we have for this deep dive. Thanks for tuning in to Workers Comp Unwrapped. Until next time, remember, great patient care is absolutely essential for recovery. But in the unique world of workers' comp, it's often the documentation that ultimately pays the bills. Thank you for listening to Workers' Comp Unwrapped. If you found value in today's episode, share it with your fellow medical providers and healthcare specialists. For more information, contact us at lena.klein@medicallienmgt.com or visit our website, medicallienmgt.com.